Historically speaking, not really. And that's in large part because we don't have a lot of long-term data on cardiac toxicity in patients that receive anthracycline or other cardiotoxic drugs. The exception is the HER2-positive patients who receive trastuzumab or HER2-directed therapy in the neoadjuvant or adjuvant therapy setting. In those patients, they typically do receive some sort of cardiac follow-up during the course of their anti-HER2 therapy, and then at least one post-treatment cardiac assessment. But for most patients who receive non-HER2-directed therapy, like those patients who are just treated with anthracyclines, we may be clinically evaluating those patients as part of our routine clinical evaluation, but it's not necessarily a cardiac-specific evaluation. I think that is changing as we recognize that there are patients who are at higher risk for cardiovascular complications of therapy as we get newer and different drugs that have different cardiovascular toxicities. And in fact, I think that may be evolving where we actually are thinking more about cardiovascular reserve, cardiovascular toxicities, and what those long-term implications are, because we're seeing patients live longer and live more fuller lives after their treatment. So I think survivorship programs are starting to recognize that, and that's part of why this survivorship guideline chose to include the anthracycline-induced cardiotoxicity algorithm in this particular edition of the guideline, because it is an important and potentially life-altering complication of cancer therapy. And we need to be able to figure out who is at risk, how do we assess these patients, and is there something that we can do to change their long-term outcomes. Right now, at the state of the data, we don't have a lot of large randomized trials that demonstrate definitive evidence that routine surveillance or early institution of heart failure therapies changes outcomes, and I think more research is really needed to really be able to show that this is important. But what we do know from the heart failure literature in non-cancer patients is that treating asymptomatic patients with structural heart disease or patients who are at risk for heart failure with ACE inhibitors can improve heart failure associated outcomes like the development or hospitalization for CHF, or the development of CHF or hospitalization for CHF, or death, and I think that, or death from CHF, and I think that those outcomes and those therapies could be translated into the survivor population. But I think more data is needed before we can definitively say that that's the case.